Hello, Docplexus community. I'm Dr. Harminder Singh. I am based in the US at Stanford University, and I'm a professor there. My area of expertise is skull-based tumors, and especially minimally invasive neurosurgery in terms of endoscopy. So today I would like to share with you the topic of skull-based endoscopy as it relates to the pediatric population. As you are probably aware, endoscopy as a field has been now growing in neurosurgery for about 20 years, but mostly in the adult population where the technique was developed, and now it's becoming more and more mainstream, and also the standard of care in many aspects of neurosurgery for skull-based tumors of the anterior skull base. However, in the pediatric population, the adoption of this is fairly new, because the pediatric anatomy is so restrictive and the instrumentation was not feasible, was not small enough to do it in the pediatric population. But that is changing with the developing technology. And now more and more pediatric applications for endoscopy for the skull base are coming, and a lot of centers around the world are starting to do it. Overall, pediatric endoscopy, I would like to say, is in children. We have at our center in Stanford done it in children as small as 2 years old. However, when we looked at the studies and we did morphometric measurements in children and the morphology of the facial bones and the structures as they grow, we found that it's easiest to do it in children who are over 5 years old. So if you are starting to do endoscopy in the pediatric population, the age from 2 to 5, I would say you would only do it once you have enough experience with the patients who are older than 5 years old. Because as the face grows, the frontal sinus opens up, and that increases the distance between the carotids and gains access to the skull base in the pediatric population. So the most important measurement that we found in the pediatric population was the intracarotid distance. So the distance between the two carotids is key in your access to the skull base, most specifically the anterior skull base. And that usually is about 12 to 13 millimeters by the time the child is 5 years old. So that gives you adequate access to the skull base. Even in kids as young as 2 years old, that distance is around 10 to 11 millimeters. So you can definitely work through that channel once you're experienced enough with the current endoscopic technology that we have. The other difference in the pediatric anatomy is that a lot of their sinuses are not aerated, so there is conchal pneumatization, which means that there is still bone that you have to drill through to get to the skull base. But that is a relative contraindication because you can fairly easily drill that soft bone away and get to the skull base. So I think in general, the rule of thumb would be if the child is over 5 years old, you should be able to do endoscopy of the skull base and treat those lesions. And even as younger as 2, once you're more familiar with the technique. There are various pathology that are just at the pediatric skull base that you don't encounter in adults. So definitely a knowledge of pediatric anatomy, but also pediatric pathology is very important when you are dealing with these diseases and treating these patients. For example, craniopharyngioma is one I would give an example, which you see in adults also, but very more common in children. And the children version of the craniopharyngioma is quite different from the adult one. It's more solid and cystic, whereas in adults it's mostly solid. The genetic makeup is different in the pediatric craniopharyngiomas. And the way you treat it is different surgically also, because there is so much hypothalamic involvement in the children that try to getting a gross total resection in kids with hypothalamic involvement of the tumor can lead to severe neurocognitive disability. And we try not to go for a gross total resection in children if there is hypothalamic involvement. So that's a key difference. The pituitary stalk is often involved, but that can be sacrificed because the hormonal treatment can be medically managed in kids. So I think if you have to make a distinction, if you can get a gross total resection in a patient who does not have hypothalamic involvement, you can definitely do it. You can sacrifice the stalk. But again, those are some of the nuances in children that are different from that in the adult population. So similarly, there is juvenile nasoangiofibroma, which is not usually seen in adults. So there's a lot of similar pathology that is just specific to the pediatric population. And we have an upcoming book that's coming up specifically on pediatric endoscopic skull-based surgery that is just being released by TEMA. And we have authors from all over the world, from 5 different continents, who are doing a pediatric skull-based surgery that have authored chapters in it. We have contributions from India. Dr. Janakami Ram is doing a chapter on juvenile nasoangiofibroma. So if you are interested in the field of pediatric endoscopic skull-based surgery, I would welcome you to check out the book as well. Thank you. So in conclusion, the key take-home for endoscopic skull-based surgery, if you're interested in doing it in the pediatric population, number one, start in children that are over 5 years old when you're starting out, before you start doing it in children that are aged 2 to 4 years old. Number two, get a good understanding of the developing pediatric anatomy because there are different growth areas that you have to protect in pediatrics so that their facial development can progress normally, especially the maxillary crest growth plate. And third, you have to have familiarity with endoscopy before you start doing it in the pediatric population. So I welcome you to try this out in the pediatric population once you have enough familiarity with it in the adult population. So, thank you.